lapsed. We want to welcome you for joining us once again for another edition of the University Research Methodology Training in partnership that is organized by the Central Office of Research, the College of Postgraduate College, and the Postgraduate Student Association. We are happy today to have another very strong facilitator who will be taking us on a specific area of research design. Last week, we focused on introducing research design broadly, and our facilitator went through the entire spectrum of what research design is. But in the next today and in the next couple of weeks, we'll be going into particulars of different areas, and we'll end this particular chapter of training with a practical session where you come with your research topic, and then we all try together to design, the research that is appropriate for your objectives. So, but then I want to welcome all of us, and today we already have in the house the Deputy Vice Chancellor, Research, Innovation and Development, Professor Akoni Akinyemi, and the Director, University Research Office, Professor Babajide Odu, who are leading this particular series. And we have in the house also our speaker, that is Dr. Barua Julius, who he's been prepared, to take this session. But let me invite Professor Babajide Odu for a very brief welcome, and then we'll just hear a short welcome also from the DVC, and we'll start. Professor Odu, sir.
Good morning to everybody. Thank you for coming online this early morning to attend this presentation. And I want to also thank our presenter, Dr. Lalade Julius Barua, for agreeing to, at very short notice, to give this presentation. I wish all of us a very good time as we listen to this presentation titled Study Designs in Epidemiology. You're all welcome.
Thank you, sir. DVC, sir.
Thank you. Because of our time, let me welcome everyone again. Good morning and welcome to this workshop. Again, to thank Dr. Barua for accepting to share his knowledge with us. So I wish us all a fruitful listening and deliberation. Thank you.
Thank you very much, sir. So, Dr. Barua is a senior research fellow in the Department of Nursing and Public Health at the University of Fort Hare, South Africa. And I think I got to know about him taking this topic at the Department of Demography and Social Statistics some weeks back, and felt this is also going to be a key session that we all are going to enjoy. So, Dr. Barua, the floor is yours. Please feel free to share your screen and then to take us through. So, Dr. Barua will speak for 40 to 45 minutes, and then we'll have opportunity to ask questions. I want to encourage everyone to please use the chat section to, type in your questions, and then so that when he is done, we can read these questions, and then he can respond to them within the hour. Thank you very much. Dr. Barua, over to you, sir.
Thank you so much, sir. Thank you, everyone, for having me today. Yeah, it's a privilege to be speaking to my able professors and other colleagues in the building. Yeah, so today's topic is all about study design, and I've been told that colleagues have been briefly introduced to study design, so I would like to go in depth this morning. Before we talk about epidemiology study design, we should try to understand what we meant by epidemiology and the key concepts in epidemiology. So, there are various ways to define epidemiology. There are so many definitions. but I've picked many definitions and I've matched them into one. Epidemiology is the study of the distribution and determinant of health-related states or events in population, and then the application of this particular concept and study, which is epidemiology, to control health problems. There are four key concepts in epi. The first one is the distribution. When we talk about epidemiology, we want to know who is affected, where there's a health-related issue or problem, and when the disease occurs. The other concept is determinants, which is talking about the causes or the risk factors of any health-related events. The third one is population, is the population, which focuses on either a group of people or just an individual. And lastly, but most importantly, is the use of evidence to prevent disease. We cannot have the distribution of disease, the determinants of disease, and the population that are affected without doing anything to control or to reduce these causes of disease or any health-related problem that we're interested in. So there's another important terminology in epidemiology, and this is what we call the epidemiological triad. As the name implied, it's a group of three things that are interrelated by one another, or that are interrelated with each other. And the one thing that I'll first talk about is the host. So when we talk about epidemiological triad, or let me first talk about the agents. So there's a bacteria, there's a virus, there's a cause of a particular disease or a particular health-related problem or event, and there is the host. So when we talk about the host, who are the affected population? Is it by age? Is it the young or the old? Is it by sex? Is it the female or the male? Is it by race, the black or the white? And so on and so forth. By marital status, by occupation, by religion, and the likes. And then there's also the environment in which the agent survives, which could be the temperature, the humidity, the altitude. Is a place that's crowded? Is it true water, milk, food, radiation, pollution, and so on and so forth. Now that we've understood a little bit of epidemiology and its concepts, now I would like to talk to us about the evolution of epidemiology. So, epidemiology is not something that's relatively new, although it is a new concept or a new formal scientific discipline. Epidemiology has been dated as far back as the 17th century, even up until the 20th century. And this goes back as when people, the forefathers of epidemiology, were using counting of health or diseases or taking vitals of who, that is male or female, where is it on this particular street or this particular household, to determine what was happening back though there was no specific name assigned to it. One of the founders of epidemiology is John Grant, who was in existence in the 17th century. John Grant is an English statistician and a demographer who lived between 1620 to 1674. And then he was one of the foremost persons who tried to come up with population health data. And what did he do? Specifically, he tried to map out numbers of birth at a particular place, number of deaths at a particular place. He went as far as then disaggregating them by either male or female. And then he was able to say, in a particular place, there are 1,000 males that were born as compared to 500 females. That was just an example. And also he was able to give us the vital statistics that Out of the 500 deaths that occur in this particular district, 300 of them were males, while 200 of them were females. That was the work of John Grant. Another interesting scholar was William Farr. William Farr was a
Dr. Barwa, sorry, we are not hearing anything. Can you please unmute Dr. Barwa? I think he's not able to unmute himself. Can I hear that?
I should be able to unmute himself.
Okay. Can you hear me now?
Yes, sir.
For some reason, the technical glitch was from your side. I was just hearing myself echoing.
No, so sorry. Thank you, sir. Oh,
Okay.
it's fixed now. Thank you, sir.
All right. So yeah, sorry for that. Let's continue. So I was talking about William Farr, who was a British physician and a statistician, and he worked at the General Registrar Office in England. And then his work focused on collecting and analyzing national mortality data to understand disease pattern in population. In essence, William Farr expanded the work of John Grant, and it was the first person who would develop the system for collecting vital statistics, which John Grant already started but wasn't really documented. And this includes having a database for numbers of birth, numbers of death, and causes of death. And then there's John Snow, who is my favorite person. At least that's what I tell many people. And then this man is my favorite person because it was the first person who then practiced what we call the modern day epidemiology today. So I will tell you a brief story about John Snow. And in 1854, there was a cholera outbreak in London, in Broad Street to be precise. Although at that time, no one knew the name cholera, and they were not sure if it was actually cholera, but a lot of people were believed to have disease which came from bad air. That was the assumption. And a lot of people were falling sick, they were dying. John Snow, being a scientific man, took it upon himself to investigate the causes of the disease and why there are a lot of deaths at that period in time. So what he did, he mapped out the cholera deaths, and what did he do in achieving this? He went from street to street, household by household, to ask questions on why have people fallen sick, how many people are falling sick in this house, how many people have died, when did it start. Such vital information were given to him. And during his investigation, he realized that there was a higher prevalence of death and morbidity in a certain street compared to the other. So he went further to investigate in that particular street the kind of food they were eating, the kind of water they were drinking, and the likes. And they found out that there was a particular pump where every one of them get water from. And those people getting water from that side were dying or were exposed to some form of disease, which they believed to be bad hair. So he then persuaded the government to change the handle of the pump. And after the handle of the pump was removed or changed, the cholera case declined. So if we go back to our 4 determinants of EPI, which was the distribution, which talk about the who, where. So it was the people who were living in the bus street, and then talking about the application of, which was the major thing I spoke about, the application of EPI. The application of its epidemiological strength here was telling the government to remove the handle of the tap of the pump and replace it, and then there was a decline in the disease and the death from cholera. This is a map showing the Broad Street, showing England. And if you look at the Broad Street, you see that there's a higher prevalence of people who were exposed to death and the disease there. And this is a trend line showing that the onset of the disease and the deaths. From month 1, the disease was almost at 0, and death was also at 0. By month 6 and 7, disease increased to about 140%, and deaths increased to 120%. And as you can see from the map, from the graph, we suspected that John Snow introduced the removal of the tap handle by the 7th month. And then you can see there's a decline in the disease. There's also a decline in mortality rate up until there was nothing by the 29th month. So this is a practical example of what epidemiology is all about. Now, let's go proper into epidemiological designs. There are 2 broad ways to describe epidemiological study or epidemiological designs. The first one is observational, and this has to deal with descriptive and analytical. And the second one is intervention study. And all of intervention studies are analytical. When we talk about observational study, from the word observe, the researcher merely observes things that occur naturally, and he can do almost nothing to intervene. And then he compares what has occurred versus what has not occurred. That is what observational is all about. I will buttress this in my next slide. And when we talk about intervention study, the researcher actively intervenes, as the name implies, intervention or experimental study, by doing something for one group and by not doing for the other group, and compare what is going to improve, or if nothing has improved at all. So in observational design, I did say it's further broken into 2, either descriptive or analytical. The descriptive investigate mainly the what, the who, where, and when of health or ill health event has occurred. While the analytical deals with the association between an exposure and an outcome. Just for a bit of context, when we talk about exposure in EPI, we're talking about what could lead, a risk, a factor to someone experiencing any health-related event or disease. And when we talk about an outcome is practically talking about an health event or any related outcomes that we're interested in. For instance, an outcome could be HIV, an outcome could be diabetes, an outcome could be cholera, and an exposure could be people who were drinking water from a particular tap or people um, who were employed or people who were married, people who were from rich household or poor household and the likes. When we talk about observational design, mostly we say there are two types, descriptive and analytical, but I have never seen any study in recent times who talked about one particular aspect of observational design, which is descriptive, and leave the analytical part out of it. Or I've never seen any study who would just say there's an association between an exposure and an outcome and didn't tell us about how many people were investigated, which is the descriptive, who were females or male, who were educated or not educated, giving us those kind of background information is important. So, in essence, both descriptive and analytical study they go hand in hand together. So this is a tree that I've tried to prepare to simplify what study design types is all about. Like I've been mentioning, when we talk about observational study, it's study that occurs naturally. You just observe, you don't do nothing about it. And it's further broken down into two, which is the descriptive and analytical. Now, when we talk about the descriptive part of observational study design, epidemiologic study design, we're talking about the single case series, and cross-sectional descriptive. Now, when we talk about the analytical parts of epidemiologic study design, we're talking about ecological study, cross-sectional
Sincere apologies. Looks like our speaker has a technical glitch. He will join again shortly, sorry.
Okay. Sorry, I don't know how this link was set up. It keeps kicking me out. So I think you'll bear with me in the meantime, please. Okay. So I was talking now, I've just explained the observational part of epidemiological study design. Now we're talking about the intervention or experimental study. So these are mainly subdivided into three parts. The first one is the before and after study, and then the second one is the quasi-experimental, which is non-randomized study, and the last one is randomized control trial. I'll go into all of these one by one. And case reports, which is descriptive part of EPI study design. Case series is dealing with a group of people with a particular disease, and they are assessed to determine if they have any kind of exposure in common to ascertain the progress of a disease. For instance, I will use an example of a group of people, like 5 persons who have one in the morning. For the first question you ask them is, where were you? Where did you go to? And then you realize that out of the 5 people, persons who went to the beach, 5 of them, 4 of them got flu. That is just a case series. It's dealing with a group of people. And another one is with just Ebola, people sick. There were some people who were isolated. That's a group of people. They were able to count the number of people who had symptoms of Ebola, such as fever, headache. The case reports, like that is who. Can you hear me now?
Yes, please.
Okay. So I was saying a typical example I usually give is the Ebola outbreak. And I did mention, like, if a group of family was falling sick, they went to the hospital, they were isolated because they have common symptoms of fever, headache, vomiting, and the likes. So they asked questions. They were able to keep numbers of people who were sick at that time, about 20-something of them. So that's a typical case series of people having a common type of disease. They don't want to know what exposure that led to that particular disease or events. But now when it talks about case reports is dealing with just a single case, a single person, one person, an individual. And in this instance, they were able to trace the disease, I mean, the symptoms of Ebola back to, I think, a 3-year-old boy who was playing around the bath somewhere. And he went back to the family. And then as a child, the family were carrying him. He was already exposed to the bath, BAT bath. And then from there, he was able to then spread the symptoms of Ebola around his family. And then the family was also going to the market or going about their daily activities, and they were able to also spread it around. So that's how Ebola case became prominent in Guinea way back, I think around 2013. So that's about case series and case reports. And then this is also another diagram to help us understand, to further help us understand case series. So case series, there's a particular disease already, which is in the present. So what do? They then trace it back to the past to look at what they've been exposed to, which in this case is the bath that the child was playing with, the dead bath. That was where it got, the virus was able to jump, or the agents, or the bacterial virus, in this case is the virus, was able to jump from the bath to the child, and the child became the host, and then it went to the environment, which is now the family, and then it was able to spread it. Then the feature in this case is talking about the progression of the disease. So they will observe it to what it's going to turn out to. Is it going to reduce? Is it going to develop into something else? So that is what the feature here is talking about. So what do we use case series for? We use to assess the natural history of a disease. We use it to generate hypotheses as to what exposure might be linked to a particular disease. And yeah, another example is COVID-19. And a case report is also similar to case series, just that in this case, it's dealing with one person and not a group of people. And I've given an example of an Ebola in the previous slides. Now, moving on to cross-sectional descriptive study. This is just study where you just want to know who, where, and then and how many are affected by a particular health-related outcome. In a nutshell, it's a prevalence study. It's just talking about how we are going to describe the burden of a disease. So a cross-sectional descriptive study, or and even an observational cross-sectional study, is something that I usually call a snapshot study. And the reason for calling this a snapshot study, because you collect both the exposure and the outcome at the same time. So let me break this down again. When we talk about cross-sectional study design, it's a quick way of testing an hypothesis. And then why the descriptive part of it is called the prevalence study, the observational part of it deals with what kind of disease or health-related outcome are you exposed to, and you also measure the possible ways that you can be having such health-related outcome. For instance, you might pass out a questionnaire. You might give a group of people a questionnaire to say, have you fallen sick in the last 3 months? If yes, what kind of disease have you had in the past 3 months? People might feel diabetes, people might feel headache, people might feel malaria and the likes. And then you further ask by asking, how old are you? Male or female? What's your occupational type? What's your level of education? So these are some of the exposure. Maybe people who are less educated don't even know the kind of disease they have, or they're able to be well informed in terms of having the right channel to take care of themselves. So it's a snapshot study that deals with both the outcome and the exposure at the same time. What do you use cross-sectional descriptive study for? We use to assess the prevalence of a disease in a community. And then we also use it to assess prevalence of disease within subgroups. We want to know how many persons in OAU, for instance, are obese. That is the general community of OAU. But when you talk about the subgroups, you want to know, are females more? How many numbers of females? I mean, how many females are obese? How many males are obese? How many people above 40 years are obese? How many people under 40 years are obese? So that's the subgroups that the cross-sectional descriptive study is dealing with. And just like I did with the case series and the case report, and this is just something to help us understand how cross-sectional study, both descriptive and observational work. As you can see, the disease, the no disease, disease status is all centered in the present. What this is simply telling us is that you collect all your data at the same time, both the outcome and the exposure, they collected at the same time. You don't have to go back to the past. You don't have to wait for progression or go into the future. You just assess everything at the same time. It's a snapshot study design. While describing the descriptive cross-sectional part of this epidemiology study design, I've basically touched parts on the analytical part of it. But just to buttress this a little bit. So a community is assessed for occurrence of disease or a disease at a point in time. That I've explained. And now we want to describe the possible association. Remember, the descriptive is just telling us how many, who, and where. And the how many there, using the OAU obesity example, was, for instance, 30 people were obese in OAU. When? In 2026. And who? Females and male. Group analysis or subgroup description, more females than male. So that is what the descriptive is dealing with. But now we want to be sure of what is now associated with the occurrence of obesity. In this example that I've given, the best bet to look at is the nutrition. So is it nutritional imbalances, or is it too much of alcohol intake and the likes? So we can then say we are sure that the association of the risk of obesity is 2 times higher among those who have who consume a lot of alcohol compared to those who don't take alcohol. We can also say that the relationship between gender and obesity is valid. And in this case, females are 2 times more likely to be obese compared to male, or vice versa, or males are 2 times more likely to be obese compared to female. So just like the descriptive part of cross-sectional study, everything is happening at the same time, all in the present. What do we use cross-sectional analytical study for? We use it to assess the prevalence of disease, which this is why I say that we cannot use descriptive cross-sectional study and leave out the analytical part of it. At the same time, we cannot use analytical part of cross-sectional study and leave out the descriptive part of it. So they work hand in hand. So we want to use cross-sectional analytical study to assess prevalence of disease in the community. We also want to use it to assess the prevalence of disease within subgroups in the community. But most importantly, we want to use it to assess exposure that are associated with a particular health-related event. This is just a question. I'll skip it because of time. Moving to case control. So this is one of the epidemiological design that is used to assess a rare case of disease. For instance, when COVID-19 came, when Ebola came, there were rare cases. So what the foremost design people, scholars and scientists use in uncovering the mystery behind these two diseases was case control. And then they use this, like I've explained, to investigate exposure in a rare disease, such as Ebola, COVID-19. It's also used to investigate exposure, which take a long time to cause a disease. That is, the progression rate is very slow. And it's also used to investigate many exposure to one disease. An example that I gave here is, even though this lung cancer is not a rare case, but this is just a typical example. To say, a researcher wants to investigate whether smoking is associated with lung cancer. The study selected individuals diagnosed with lung cancer and individuals without lung cancer, which is not the control. So the case is those with lung cancer, the ones without the lung cancers are the control. And then he collected information over their past smoking history. And perhaps in the study, those who are more exposed, let's assume that he has 10 controls and 10 cases. 10 control means 10 people who are not smoking, and 10 cases mean 10 people who are smoking. They collected information over time, that is in the past, to say, how often do you smoke? When was the last time you smoked? How many packs of cigarette do you smoke? And then let's say out of those 10 cases, maybe 9 of them were smokers. So they are able to determine that smoking is actually exposed to lung cancer. And there are also some instances whereby in your control, 10 of them don't have lung cancer, but they are also smokers. We will get to that when we talk about chances, bias, and confounders in study design. So this is a typical example of a case control study, which was extracted from Beguho and et al. In 1993. So there's a case. In that case, there's a population. Let's start with the population because it's a retrospective study. You deal with history. So there's a population of people. And then you realize in that population, some have lung cancer and some don't have lung cancer. So you then divided those who have lung cancer as the case and those without the lung cancer as a control. Then you trace them back to say, are you exposed to smoking? Out of the 10 people who have lung cancer, 8 of them are exposed to smoking and 2 of them are not exposed to smoking. So there might be other factors that might be linked to lung cancer. That is why we say that with case control, you can actually assess many exposure that can be linked to a particular disease. And also coming to the control, there are those who are exposed to smoking, but they don't have the lung cancer. And there are also those who are not exposed to smoking, and they still don't have lung cancer. So this is a typical example, just like I did for cross-sectional and the case series. The case control is a type of design that is happening at present and is being traced back to the past or history. So it's a retrospective study or design. And the disease has already occurred, but you want to trace back to history or to the past, the kind of exposure that may be linked to that particular disease. Now, moving on to another study design, which is cohorts. Cohorts is a kind of study design that follow up a group of people over a period of time. There are two types of cohort study. They can be prospective, that is going forward, or they can be retrospective, that is going backward. So I will talk about the prospective study design. I'll talk about the retrospective study design as well. So when we talk about, first of all, a cohort study is used to measure new cases of disease, which is the incidence of disease, and assess which exposures might have caused that particular disease or the health-related event. And this is where you get your certainty from. Unlike your case control, unlike your cross-sectional, you're able to determine that A causes B. In our language, we call it, you're able to determine causality. In other studies design, such as the case control and the cross-sectional study design, you're talking about mere association. A can be associated with B, B can be associated with A. Nutrition can be associated with obesity, obesity can be associated with nutrition. But if you want to be certain that an exposure can cause an outcome, a particular disease or health-related events, this is the kind of study design that you need for your study. It's either you use a cohort study, which is very, very difficult to do because it takes considerable number of time. You have to follow up a group of people. You also have to have the necessary resources. You have to have the money to do this. The other study design that you can use to get causality is your randomized control trial. We'll get there, right? So typically in cohort study, it compare a similar group of people without the exposure. That is, at the beginning, they are not exposed to anything, and they also don't have the disease. Then you follow them up until maybe every 5 years or every 2 years or every 6 months, depending on the timeline that you set for the study design. And then you follow them up until they experience a particular health event. For example, I would say you follow up a teenage girl from the age of 13 up until the age of 19 to see how many of them will experience teenage pregnancy. That is, at the age of 13, none of them were pregnant. Then you trace them, you follow them up every year, you give them questionnaire or you monitor them up until they were 19. And at the end of 19 years, you determine maybe 20% of them were already pregnant. That's how you determine. That's what you do with cohort study. You follow a group of people without the exposure or the disease or the events at the beginning. You follow them up until they experience the event, which is now pregnancy. Then you will now investigate what are the exposure. Were they having multiple sexual partners? Were they having unprotected sex? Were they having transactional sex? Those are the kind of exposure that you will find along the line. And just like the name implies, prospective cohort study, you're looking at the present, they are not exposed. They don't have the disease in the present. Then you follow them up till they have that disease into the future. Maybe you follow them for 2 years. Maybe you follow them for 5 years. There are cohort study that are being followed every 10 years, depending on your research question. And then when you talk about retrospective, in this case, the disease has already occurred. And then you want to trace the exposure back to trace it back to the past, what they've been exposed to before that disease occurred. So what do you do with this kind of study design? So it comes criminal group without exposure, and in the past, and assess to see if they have the disease, or to determine if the disease is more common in the exposed group compared to the unexposed group. A typical example, I don't want to use smoke and lung cancer again. let me use treatment adherence in HIV. So you had gone to a clinic and then to see how many people have defaulted their treatments. So already they've have the disease of HIV, but now they're on treatment. And you want to now investigate how many of them have stopped coming for their treatments. So what do? You go back, take the clinic record and see how many people enrolled in the past. Maybe you want to trace it back for like in the past 2 years or in the past 1 year. And then you see that at a particular point in time, maybe out of 50 people who were enrolled in ARV treatment, maybe 20% of them have dropped out. Then you want to investigate what might have led to that dropout. You then check maybe the distance to the hospital was far, or maybe it was because of their financial status. Maybe some of them are from low economic, socioeconomic background, or maybe it's because of education. They have low education and they don't think about the consequence of dropping out of their ARV treatments. So just as the name implies, retrospective, you look at the present and take it backward to the past. And what do we use retrospective cohort study for? When one wants to measure the new case of a disease incidence and assess which exposure might have caused the disease, with the certainty that the exposure was present before the disease appeared, and when you have good records of both exposure and the disease. The difference between the retrospective and the prospective cohort study is just that. You with the retrospective, you have to deal with records, clinical record, because you cannot go back in past to observe things. But with the retrospective, you can see it by yourself, how people progress from not having a particular disease or any health event into having that particular disease or the health event. Moving to the intervention study now, talking about the before and the after. So, a typical example that I give in a before and after study is hand hygiene program to reduce hospital-acquired infection. So, you give soap and water to a group of people in an hospital, or who goes to the hospital to say wash your hand, and then you don't give what is it called? And then you observe after maybe like 2 months or 6 months to see if the rate of infection from the hospital has reduced or not. So in this case, there's no scientific method that you need in this kind of study design. You just, it's a non-randomized control design. It doesn't need your sampling. It doesn't need any typical strong methodologic approach to carry out this kind of study. So what you want to see is an intervention that you're suggesting, is it going to work after a period of time, or is it not going to work? But the limitation with this kind of study design that it's always confounded. And then when we talk about confounding, a confounding is that kind of variable or factor that will affect the outcome and also affect the exposure. In this case, you suggested hand hygiene program to reduce acquired infection. The possible confounders that can happen here is, what about if people don't have money to buy soap to wash their hand? It's going to affect the results. So those are the kind of confounders that can happen. Also, age is another important confounder in any research. So, for instance, you cannot expect a 5-year-old to constantly keep to wash their hand, and you expect that people who are at least above 18 years to be able to monitor their health properly. So, when we talk about the before and after study, so you talk about the past, what has happened in the past, people are having a lot of infection whenever they go to the clinic or hospital. And then you intervene in the present, and then you wait after 6 months to see, which is now into the future, if there's a positive outcome or there's a negative outcome. Now, this is randomized control trial. It's one of the strongest study designs ever when you're dealing with causality. It's widely used in medicine, pharmacy, and in public health. So, in randomized control trial, RCT, just like the case control, there are groups. One is the control and one is the intervention group. The intervention group receive an experimental therapy, or you intervene to a particular group, and on the other side, you do not do anything. I will not use this example. I will use a cash.
Yes, sir.
A cash. Yes, sir.
Yes, sorry. We are really just you just have 2 minutes for the entire program left.
Okay.
Yes. So I wanted to ask if it's
are,
possible to break it into 2, and then probably complete this next week.
No, we have just 2 more slides, and then we're done.
All right. Okay. Thank you. Thank you so much.
Yeah. You're welcome. So with randomized control trial, as the name implies, everything has to be done scientifically, which means both the intervention group and the control group have equal chance of being selected, and it's always double-blinded or blinded. That is, the intervention group don't know that you're giving them the intervention, while the control group don't even know that you're not giving them anything to intervene. For instance, in the case of COVID-19, some are given the vaccine, some are not given the vaccine. Both are given the vaccine. So one is a placebo, one is the actual vaccine, but none of them know which one is a placebo. A placebo is just like a form of intervention given. It could be an advice, it could be a vitamin, just to make sure that it looks like they've been also given an intervention. What do we use randomized control trial for? We use it to assess possible cure or treatment or prevent any form of disease. And we also use it to compare new cure or treatment or prevention of a disease with an existing one. So with randomized control trial, just like I've done with the other one, everything is happening in the present, and then you assign intervention, and then you wait and see what the outcome looks like in the future. So, like I did say, everyone has got an equal chance of being selected into a group or intervention group. And the last one is quasi-experimental, which is a non-randomized control trial or as our intervention design. So a typical example that I give here is a mobile clinic that we introduced in one of our studies that we did about 5 years ago, where we try to improve child immunization. In a particular group, we provide them with mobile clinic, and the other group, we didn't provide them with mobile clinic. We expect them to go to the hospital or the clinic to get vaccines for their children. And at the end of the day, we found out that those that we provided mobile clinic were able to have their children more vaccinated compared to those that were asked to go to the hospital. So we selected based on convenience. We didn't care about everyone else getting an equal chance of being selected into either control group or intervention group. And then, just like the randomized control trial, we intervene in the present and we follow them up into the future to see if we're going to have positive or negative outcome. So, thank you.
Thank you very much, sir. Thank you so much. We apologize for the network glitch. We really don't know why. But then, of course, internet is sometimes really unpredictable. However, we appreciate the way you are able to calmly take us through how all of these designs work. And I think it's easy to follow and understand. what you have taught us, especially with the examples. We want to say thank you very much for also taking time to do this, for sharing, from your wealth of knowledge. For those who were asking questions about how to get the slides, because this invitation is shared widely and we don't have all emails, what we do is we are also streaming this live on YouTube, and we have people who also joined via YouTube. So definitely you can just go to our YouTube page. There's already a prompt in the chat on how to get there. Search for OAU Central Office of Research. And then you can see the recording for this session and other previous sessions that we have had. So I want to thank our speaker for taking time to do this, and then for taking out of your very busy schedule to take us through this very, very, very helpful session. And I want to invite Professor Babajide Odu to remark for his remark, and then to also help us close the session. Once again, we apologize for going beyond 9 to everyone, but then especially to our speaker for the network issue. All right, Professor Odu, sir.
Yeah, thank you, Olajimiji. I want to thank Dr. Baruwa for this presentation, and to thank everyone who attended. So we believe that by next time it will be better, considering the way that the internet was, misbehaving. It's normal. So, and I want to thank us and then ask us that we'll expect to also join and have a better another presentation next week. Because willing. Thank you, everyone. Thank you so much. See you next time.
Thank you very much, sir. Thank you, everyone. Thank you so much, our speaker. Thank you, everyone. See you next week. Same time, same link. And of course, would also have same quality, or, it keeps getting better every week. And for next week, we'll be sending some notice out early so that we'll how to prepare for next week's session, and then we can move. So thank you, everyone. See you next week. Bye.